Stationed at Fort Lewis for a year before starting the Bravo Comprehensive Program at Fort Hood. From there, he went to teach as an APD and PD at Fort Sill, Oklahoma. Currently, he is stationed at Presidio Monterey and is one of the consultants of the digital dentistry for the Digital Dental Directorate. We are all excited and honored to have him here for the week and looking forward to his CE presentation.
Thank you. I'm actually from the great state of Michigan, but I went to dental school at Case Western. So, any Michigan grads in the room, if you don't like my presentation, blame it on the state of Ohio. So, but I am from the Ann Arbor area.
Did Michigan lose Michigan State?
Let's not talk about that. Let's just. It's not a way to start my presentation. Ruin it now. So this lecture kind of spawned off a couple of topics. So you may have heard there's a lecturer, Marcus Blatz, who talks about the APC concept for bonding zirconia. But the problem is it only applies to dental zirconia. It doesn't apply to a lot of the CAD CAM materials that we have in our armamentarium. And this conversation always comes up with dental residents, how do I bond these different materials? So we kind of came up with this topic of the ABC approach to bonding all of our CAD CAM restorations. So like anything, I want to make sure that I am a good military doctor here and say that these are not the views of the United States government. These are my views and my views alone. I don't have any financial interest in any of the companies or products that I talk about. All my images that I have are authentic. I have not altered them other than maybe rotation, flipping them, or adjusting contrast. Other than that, if there's any other alterations, I will definitely let you know. So the basic outline that we're going to be talking about today is we want to discuss and understand the biology of the natural dentition. So I always start to focus with like the why we're doing what we do. And so with this, as a dentist, we have to focus on biology first. We have to be a good engineer when we are a dentist as well. So we're going to focus on some of the engineering principles and apply some of that material science and decision making to how we design our restorations. And then ultimately, we want to distill down the chemistry of our resin cements into 3 phases. So if there's anything to take away from this, anytime you're trying to bond any restoration, you need to have an A, which is acid or air abrasion. You need to have a B, which is a bonding intermediate. You need to have a C, which is the proper cement choice. So anything that you're trying to chemically bond, you need to have an A, you need to have a B, and you need to have a C, and they have to be the right A, B, and C to get a good looking restoration. So I would be remiss if I didn't tell you this. One of my former residents is in the room, Dr. Peter Heitman. He did an excellent presentation for the end of the year at the Fort Sill residency on bonding. So I did repurpose a couple of his bonding slides with his permission, which he then told me he actually repurposed them with my slides. So I'm not sure if they're my slides or his slides or somewhere in between, but a couple of these do belong to Dr. Peter Heitman. So what is bonding? Well, from the simplest term, what we're trying to do is we're trying to attach a material to a tooth surface. So when we apply that to the surface of substance, we want to join them together to resist that separation. So there's lots of ways that we can do that. We can do that through micromechanical means. We can do that through flooding our dentinal tubules and our hydroxyapatite and collagen matrix with some sort of a hybrid layer. We can use these chemicals that are in here, like 10-MDP, to actually get a chemical bond to our hydroxyapatite. There's many ways that we can do this. And dentin bonding in and of itself is a whole other topic. So we're not going to try to broach too much on that topic today. We're going to focus really on how we stick the crown to the tooth that has this surface applied. So when we think about digital dentistry, the one thing that we have to realize is this stuff can get really, really confusing. And I think this is one of the major roadblocks for dentists, is this stuff starts floating through your head when you're trying to do an all ceramic restoration in one visit. You're thinking, do I have this peripheral rim of enamel? Do I not? Is my tooth endodontically treated? What's going on? When do I do an inlay? When do I do an onlay? When do I do a full coverage crown? So we're going to talk a little bit through this matrix as we kind of make our decision-making process and choose the proper material. What I want to tell people, because I don't do CAD CAM for everything, there are times that I don't use CAD CAM. There are times that I use gold. There are times that I use other modalities of treatment. So it all fits into my decision-making process, and this is something that we're going to discuss throughout this presentation. So in the Army Dental Corps, we don't typically have the luxury of getting to restore virgin teeth. I I'm not on Instagram. I took a break from Facebook and social media because dentistry like floods my life when I'm on there. There's all these Instagram dentists posting these beautiful restorations of teeth that I would never get a chance to restore because that's not the reality of what comes into my clinical practice. This is the kind of stuff that I see on a daily basis. A patient comes in a sick call, they're having pain on biting on the lingual cusps. When we look at it with a tooth sleuth, we've got multiple different restorative materials in this tooth. So this is actually a patient I saw last week. So I figured this would be good everyday restoration to walk you through my thought process of material selection, material design, and ultimately the ABCs of all ceramic dentistry. So we have to ask ourselves from a biological engineering perspective, where do posterior teeth tend to break? Well, there was a study by Bader in 2001 that looked at the teeth and their fracture patterns. What they typically see, it's not your loading cusps that will typically fracture. What you typically get on the mandibular teeth is you get the lingual cusps that will fracture under function. And you get on the maxillary teeth, you get the buccal cusps that fracture under function. When we think about the mandibular teeth and where we see this marked occlusion on this patient, think about how that tooth is angulated, right? We have a lingual angulation to the tooth. When we prep into that tooth with our burr and create an undercut, we're creating this mechanical, unsupported enamel in an area that we don't necessarily have a good opportunity to see. Luckily for us, when these teeth tend to break, they don't tend to break in an unfavorable manner that we can't restore them. And what these teeth typically present at that I find is when a patient comes in on sick call, they have sensitivity to biting, we see some leakage around this composite. We also see the patient has been biting on these areas because the dentist took this restoration out of occlusion. So to me, it tends to present as pain on biting with mild pain on release. So if you've seen so far, I like QR codes. I like to be kind of high tech, but with my burr blocks, I tend to be very minimalistic. So I like to make sure that I'm being a good steward of taxpayer money. So I want to show you, we don't use anything fancy to do these styles of preparations. This is the burr block that we use in our clinic for just about everything. We have a single carbide burr, which is a 245 for doing all of our direct restorative procedures and to do our depth cuts. We have our selection of diamond burrs that are all single-use diamond burrs to do any sort of occlusal reduction we may need for CAD CAM. We have a couple composite finishers, a couple carbides to remove any sort of carious dentin, and then we have a couple finishing strips. So if you're interested, what's available to you in ECAT, if you like a minimalistic burr or even a non-minimalistic burr, you could take a picture of with your phone of this QR code, and this will pull up a little PowerPoint slide that has all of my burrs that I use for this entire presentation on a little PowerPoint slide that has the ECAT ordering number on there too. So that way, if you're interested and you wanted to order it, you could absolutely do that. So to walk through this case, after I anesthetize the patient, we typically will use a 245. Because our cutting length is about 3.2 millimeters long, I use about half of it to give me a depth cut of about 1.6 millimeters. And this is the burr that I use right here. It's just a Meisinger singles, and this is the ECAT number below. But this is essentially making this kind of a paint by numbers style situation. So I also use it to break my interproximal contacts. Once we go through and we do that, we need to go ahead and we need to reduce the occlusion on this patient. We know that there's a fracture happening somewhere, so we want to get that cusp out of the way. So for that, I just use one of these barrel-shaped diamonds turned on the side with the shank of the diamond either facing the buccal or lingual to get a really basic and fast occlusal reduction. Once we do that, we use this coarse round end diamond to kind of finish our preparation, and this is where we start to evaluate what type of restorative material we're going to use on this tooth. So as we go through and we do this type of preparation, we can see that we do have a little small fracture here. We have a small little fracture right here. But overall, we have a really nice intact peripheral rim of enamel. So overall, this is letting me visualize my substrate of what I'm going to bond to. So not to cloud this slide with my overall thought process or decision-making process, but you can see that my peripheral rim of my tooth is completely enamel. So when I look at that, I have to think of engineering. and we think of elastic modulus. So I want to use something that has a very stiff or high elastic modulus. So I'm going to stick with a ceramic material when I have a peripheral rim of enamel to bond to. This tooth's not endodontically treated, so I don't automatically in my mind have to go towards a full cuspal coverage restoration. But because it's not, what I'm looking at is over half of my interocclusal width of a proximal surface is actually restorative material. So then I have to look at my remaining wall thickness. So on this tooth, every one of the walls that I had present either had a fracture or it was less than 2 millimeters thick at the base of my preparation. So we had to get rid of it and do a cuspal coverage type of onlay. So some of you would code this out as a crown, a W2740. Some of you would code this out as an onlay. I think that's really a matter of preference in the military, how you want to code it out. I think in the private sector, because I have a circumferential preparation and I've covered all 4 cusps, I would probably code this as a crown. But for me, I view this almost as an onlay style preparation through this thought process or thought matrix that I use. So when we break this down and we think, what are teeth actually, right? It's not like, humans are the only ones that have teeth. It's used in all vertebrates to break down food. So we've done CAD CAM restorations on military working dogs. I think there's been one that's been done on a polar bear. There's been one that's been done on a Bengal tiger. So what happens is, that tooth is going to be stressed, right? We use that to get food into our bodies. So depending on what type of vertebrate we are, it depends on what type of food we eat. So if you're an obligate carnivore on the top, your teeth may be shaped from a form and function style to get that type of food into your diet. If you're an obligate herbivore, like you see on the cow's tooth on the bottom, you're going to see that the tooth is shaped totally different, right? So the form of the teeth follow function. And so with the residents this whole week, we've kind of been talking about form following function and understanding how that biology and engineering kind of play together. So we used to think that anatomy is Wolff's law. So how long bones grow in the body, we would consider it that the form would follow the function. But when we think about human teeth, we're not obligate herbivores. We're not obligate, carnivores. We're kind of somewhere in between. We are omnivorous. So with that, mastication plays a huge role. What we have to do as dentists and restorative dentists is understand that we have different forces, than a dog or a cow. And a lot of our forces are combined. We don't just have compressive style forces. We have a mixture of tensile and compressive forces. So I think pathophysiology plays a huge role in this. This is the kind of stuff that I see every day in the Army. This is a sick call patient that I saw in tandem the same time while I was doing the patient we just prepped. This patient came in with a broken composite restoration. So you can see where the occlusion is at. This patient, they were biting down on a piece of candy, right? So pathophysiology definitely plays a role in how we restore teeth. We had decay, we restored it with a weaker material, and it fractured right where that patient bit down into a gobstopper. So when we think about bonding and we think about our all-ceramic restorations, we keep mentioning that rim of enamel. So it is the hardest substance in the human body. It's a quite amazing substance when we think about it, right? Because it is more of a rod style of feature. When we talk about how those rods are distributed, they are, almost completely hydroxyapatite, but the way that they emanate from the tooth is also how our tooth responds to compressive style of forces. So enamel by itself wouldn't be a very good restorative dental material. It would be weak, it would be brittle, it would break almost instantaneously. It protects the dentin, but it's also supported by the dentin. It truly gives our tooth shape. So with the residents this past week, we were talking about staining posterior teeth and where teeth are higher in value and where they're lower in value. Well, it's really interesting because that shape doesn't necessarily come from the enamel itself, but it comes from the way the tooth is shaped and the way the light is reflecting off of these cuspal surfaces. So when we bond to this enamel, we have to understand that rod style of structure. We have to understand that it's composed of these prisms, and when we etch these prisms, we get different styles or different etching patterns. So these prisms are hexagonal in shape, and they run parallel to the DEJ. So as we're prepping these teeth, we have to understand that when we prep and have something like a J-shaped margin and we engineer that restoration, that we're not going to set ourselves up for success if we run a restoration that way. So When we're bonding to enamel, the one thing that we have to keep in mind and remember that water and enamel bonding definitely do not mix. So when you see the restorations that I'm going to be presenting in this presentation, I like to use rubber dam isolation. So when I do talk about minimally invasive CAD/CAM preparations and bonding, isolation is absolutely key. We'll talk a little bit more about that in a couple slides. But what I want you to think about with enamel is predictability of that enamel bond, right? It's really technique insensitive if you take moisture out of the equation, and it's purely micromechanical in nature. So the way that we do this should be a review for everybody, right? 30 to 40% phosphoric acid etch, 15 seconds to get a frosty appearance, 15-second rinse, and we should have about a 10 micron deep type of micro etching pattern. So what's the goal from there? So once we do that, we have to understand those hydrophobic monomers are going to get in and create these little resin micro tags, which coat over top of that enamel or glassy surface. So Dr. Nate Lawson has a really good presentation on enamel and dentin bonding in a contaminated environment. So if you ever have a chance to follow him, I think it's called the dentinal tube or the dentin tubule. It's a little podcast series that he runs, and he talks pretty extensively about what happens when you get contamination of your enamel bond. So when we look at this, this is kind of what we like to see, okay? So you can see that we have this kind of etched frosty pattern around these occlusals that were a stock photo, I think, from Dr. Heitman's lecture. When we're doing this restoration that I prepared on the bottom, what we want to see is, again, this nice frosty pattern of our enamel all the way around this tube. But however you're going to isolate it, whether it's a rubber dam or whether it is an isolite or an isovac, you have to make sure that moisture exclusion is adequately there, and that is of utmost importance. So now we spent a little bit of time talking about the predictable peripheral rim of enamel that we're trying to bond to in this restoration, but really we need to focus on our dentin. So typically, if we don't have a large composite restoration in a tooth, it's the most abundant part of the tooth that we're trying to bond to, but also it's got this tubular type of feature to it, right? We know that dentin is more of a dynamic tissue. You know, it has these collagen fibers, and the analogy that I like to use is it almost looks like a nerd rope. Anyone ever eaten the nerd rope candies before? So you have this little piece of licorice that are coated in these little thin candies on the outside of it. So think of that like a collagen, and then on the outside of that, you have these little interspersed nerds. That's your hydroxyapatite crystals on the outside of your collagen. So we don't want to strip those off of there. We want to use those in our bonding process. So when you look at it, we still definitely have a lot of hydroxyapatite in there, but we definitely have a lot more organic matrix as well. So this is where the color of our tooth comes from. So when we're understanding all of our restorations for CAD/CAM, we have to understand if we have an enamel-bound restoration that's very thin, you're going to be very limited on what colors you can modify your tooth to be. Because dentin and areas like this kind of dark area of dentin from an existing amalgam restoration are really going to affect the final outcome and the final color of our restoration. So again, when we have this material right here, I wanted to show a couple of these pictures to show you that little dynamic type of change. So as our tubules get closer and closer to our pulp from our DEJ, the diameter of that tubule gets larger, and we have less effective surface to bond to. So we have to understand that it's not just like a uniform piece of Swiss cheese throughout. The deeper our dentin is, the more technique sensitive it becomes for us to bond to. So it is dynamic, and it's going to react to any sort of that external injury we have, like you saw in my patient up there. So with this, we don't want complete moisture occlusion. Some water is absolutely okay, right? So I say on this one, don't think of it as you can't bond to dentin, but think of it as it is so technique sensitive that your durability can be very, very questionable, okay? So when we think of dentin conditioning, we don't necessarily always do a total etch approach. There's some great resin bonding studies out there, and there's times that I use a 4th generation system. There's times I use a 6th generation system. there's different techniques depending on how deep you are in the tooth. So using total etch, which would be taking phosphoric acid, rinsing these dentinal tubules clean, putting in a primer, and then a bonding agent over top of it would be something like a total etch technique. A lot of these cements that we're getting nowadays that we're selecting as part of our A, B, and C step for bonding our restorations are actually going to be more of these self-etch acidified monomer type of solutions, something like 10 MDP. So it's very important to understand that if we are using that self-etch approach, that it's going to preserve some of the occluding material in these dentin tubules, and we're modifying that smear layer on that tooth to make a more uniform, what's called hybrid layer. So the depth of that demineralization definitely depends on what type and what strength our pH of our acidified monomer is. So 10 MDP, which is Scotch Bond Universal, Clearfill SE, that material itself is typically in the range of about 2.5 in its pH. So it's what we consider a mild self-etching material. So typically when we look at the studies, those perform the best when we're looking at self-etches. Strong self-etch like Prompt L Pop, which is something that has a pH of around like 1.5, typically performs pretty poorly because that over-etches our smear layer, denudes too much of our hydroxyapatite off our collagen, and causes our restorations to be susceptible to what's called hydrolytic degradation or breakdown of water over time. So we have to think that these 1 and 2 step approaches can also be added too. So you can have a total etch system that's 3 bottles. You can have a total etch system that's 2 bottles. So we have to understand what bonding agent we're using. On a lot of the teeth we work on, because we don't work on perfect teeth, we do have sclerotic dentin. Understand that sclerotic dentin is going to impact our dentin bond to these restorations. So we're going to have a very non-uniform appearance to our dentin substructure, which is going to affect our etching patterns. So typically if we're using a self-etch and we have a collagen and hydroxyapatite matrix that's present, we can get relatively predictable results to that sclerotic dentin. When we're using a total etch type of system, if we're trying to get down into those tubules, it can be a little bit inhibited by the irregular pattern. So I like this picture from Dr. Heitman's lecture, so I kept it in here. Contamination of bonding is super important. Okay, it's super important for us to understand. As we're going through, we kind of breeze very quickly through our dentin bonding because we have to understand that's something that you all do every day. You have your own techniques, you have your own ways of keeping it clean, but when we're doing crown preps, a lot of people, and I don't mean to sound mean, kind of get sloppy. What we would usually use a rubber dam for when we're prepping a DO composite, we take the rubber dam off and we're trying to prep a crown and we're trying to bond a crown without a rubber dam or proper isolation. So you have to understand that dating all the way back to 1975, moisture contamination, we knew that that was a problem, right? When we look at bond strength, 70% reduction in bond strengths when sealants are placed on etched surfaces that have been contaminated by saliva. Okay, well, what does that mean? Well, that's what we said, water and sealants don't mix, right? So if we have that peripheral rim of enamel, why not try to protect it when we're trying to bond our all ceramic CAD CAM restoration? So whenever we do get saliva on the tooth, or whenever we are ready to actually bond our restoration, our crown on the tooth, it is important for us to re-etch or re-clean the tooth prior to our dentin bond. So even if you do something like an immediate dentin seal, which we're going to talk about here in a couple slides, it's important that after that sat in the patient's mouth, we remove all of those phosphate contaminants and get that surface ready to bond to again. So good isolation isn't just for the protection of our bond, it's also for the protection of our patient. So in the Army Dental Care System, we tend to be a very high reliability organization. A lot of group practices tend to be high reliability. And so when using good isolation, it's important to remember it's to protect our patient too. So this was actually one of my dental residents who was fighting with an isolate on this patient and decided he didn't want to use the isolate, took it out of the patient's mouth, didn't want to use rubber dam, and the patient moved, burr moved, and now we have said hole in the floor of the patient's mouth. So after, kind of cooler heads prevailed and bleeding was controlled, we're able to snap this picture really quick. But it can happen to anybody, right? I use rubber dams or isolites or isovacs for most of my preps. This happened to me not that long ago. I was using an air turbine handpiece, and it literally exploded in the middle of a crown prep. That came flying off. That came flying out in the patient's mouth. If we didn't have good isolation, I don't think I'd have ever found all those little BBs that are floating there, those little bearings that were part of that broken bearing housing. So if you are working in an Army dental clinic, understand that the Army Clinical Practice Guideline does require this for all restorative procedures, either a rubber dam, an isolite, or a similar product like a Mr. Thirsty or some other type of isolation device. And if you don't annotate it in the dental record, or you're supposed to annotate in the dental record, one thing that I would say, and I kind of count my lucky stars, is that I did use a rubber dam when I was prepping this tooth. I did catch all the pieces. And so my dental record, when we did the root cause analysis on why that handpiece flew apart, I wasn't also filling out a patient, harm analysis. There's no harm to the patient because we were following the Army Clinical Practice Guideline. So it's something to keep in mind. A lot of people ask when we're talking about the ABCs of bonding crowns, before we get to actually bonding the all ceramic, what do you do to your dentin? Well, I tend to do an immediate dentin seal after I cut my preparation. Well, why? There's a lot of reasons. One of the reasons is kind of just very basic. I was telling the residents I have young kids, and if I buy a new piece of furniture, my kids are going to do everything in their power to destroy that piece of furniture. They're going to get dirt on it. They're going to get it all dirty. So before that piece of furniture ever touches my children, I Scotch guard the heck out of it. I'm spraying it down so that way I can clean that fabric when my kids eventually spill something on that fabric. Dentin, when you look at it under a microscope, has all these little collagen interweaving patterns that almost look like carpet. So you have to think, the second you take that rubber dam off the patient, they're going to be rubbing their tongue, there's going to be blood, there's going to be saliva that's going all over that tooth, and now it's going to be more difficult for you to clean. Now in a single CAD CAM appointment, is it that big of a deal? Probably not. But in the studies from Monnier, studies by CAD, when they look at longer term provisionalizations, our bond strengths are increased by placing that immediate dentin seal. What I find is that it reduces my pulpal irritation too. So in my patients, if a provisional does come off, the patient isn't holding their tooth and they come in. Generally speaking, they have mild to even no sensitivity. It helps prevent coronal leakage. So if you do have an endodontically treated tooth and you seal over top of the dentin, and you do have a break in that restoration or an exposure of that endodontic access, I tend to feel a little bit better because we don't have a direct pathway for bacteria to reach the endodontic treatment. It improves our bond strength, right? So it allows for that dentin bond to mature in a controlled environment prior to us actually trying to bond a restoration to the tooth and involve an entirely different chemical process. It preserves tooth structure when we're trying to block out undercuts, right? So if you look at this study by Nikado, there's times where you maybe have a little undercut inside your preparation, but if we do some sort of a resin coating, we can block out those little restorative areas that maybe you would have to remove tooth for an undercut that we would do previously. It allows for an easier insertion of our restoration. Well, why is that? When we have a nice smooth preparation, that when we blow it up 20 times on a CAD CAM screen, we don't see every little burr mark or every little chatter that our handpiece made. We end up having a much easier time taking this restoration on and off. So how do we do it? How do we do an immediate dentin seal? Well, first, you have your preparation and you smooth it as clean as humanly possible. What I like to do is after I get my preparation done, I use a caries disclosing agent to paint over top of my tooth, and then I rinse that caries disclosing agent off. It's not only going to show decay, but it's going to show areas where maybe I have a little bit of retained plaque, which could interfere with my bond. Areas where I have dentin that maybe isn't of the highest quality that has been affected by the caries process that's going on. So then I'll go ahead and I'll clean all of those areas off to ensure that I have a really good, smooth, clean substructure. Then moisture exclusion, right? So we make sure that the tooth is dry. You can see this little circle back here. So when I'm doing my crown preparations on this patient, we started with an isovac because we didn't know how extensive this decay was going to be. I then apply my coating treatment. So my low viscosity, or my bonding agent with my low viscosity resin. So what I'm doing here is applying my Scotch Bond over top of the tooth. And then what I do after I apply those is I take a dry brush and kind of brush up the edges of my restoration to soak up any additional material that we see. To remove our excess resin, what I actually will do is take a fine diamond and go back around my margins really quickly, just to make sure that I remove any sort of spikes of resin off of any of my margins. And then we're ready to place our final restoration. So we've taken care of the tooth at this point, right? So I've sealed off my dentin, I've got everything prepared to go, and now I'm only worried about sticking that crown to a resin substrate. So now that we've gotten the tooth taken care of, and we try to restore that dentin enamel complex, which when we know how teeth work, isn't necessarily a simple interface, right? When we see these enamel tufts and this dentin enamel junction, it's not a flat interface, right? A lot of people kind of glaze over this, and we look at it every day when we're doing restorative dentistry, but we don't understand what's actually involved in it. It's kind of, when you think about it, almost like when you're doing construction work and you have concrete with rebar that extends into the concrete. These enamel tufts will go through the dentin enamel complex, and what it'll do is it'll take tensile forces and convert them to more of a compressive style of load. So it's a very interesting surface, and when you look at it, I say it's more of a complex than a junction because it's got many different connected parts and pieces. It's not just a very straight joined surface. The last thing we have to think about too is the pulp. Okay, so I actually had the opportunity to do a really cool joint project with our endodontist on this. So I always want to leave this for the endodontist in the room and the people that are interested in this topic, right? So we can't forget the pulp, because anytime we touch a burr to a tooth, it's going to be affecting the nerve of that tooth and the tissue associated. So many times as we're working on the nerve of the tooth, we end up near or in the nerve of the tooth. And one of the topics that always comes up with this is looking at our pulp vitality. When we do have a pulpal exposure, how do we cover up that pulpal exposure? What do we do about it? Well, the Army Clinical Practice Guideline is kind of vague, right? It gives us the ability to do a definitive pulp cap for small mechanical exposures, but it doesn't allow us to do them for caries exposures. So I had the opportunity to talk to Dr. Duttner. He provided me these slides that you see right here of different type of pulp capping materials. When we're doing crown and bridge work, sometimes we get near a pulp horn. Does that mean that the tooth is always going to require endodontic therapy every time we get near a pulp horn? Well, how many people, show hands in the room, when you get near the pulp, use something like Theracal? Who uses Theracal? Anybody? Anybody use just a glass ionomer, something like Vitribond? Okay, Vitribond. All right, but it's a resin-modified glass ionomer, right? Okay. Okay. What about anyone use Biodentin? Couple Biodentin folks. Okay. So, just as a little kind of aside, when you look at this presentation here, usually there's a lot more Theracal people out there. Theracal is a calcium silicate, but it has a resin component. But Vitribond will work for this example too. So this is actually a picture right here of a pulp exposure with a restoration placed with Theracal. What you're seeing here is this dispersed mineralization and a micro abscess forming on the tooth from its response to the resin monomer that's in that material. So if you have a direct mechanical pulp exposure, please do not put a resin-containing material over top. In this study, they actually found that only 11% of teeth that were covered with Theracal formed a continuous dentinal bridge. So if you are prepping a tooth and you happen to get a little bit happy with your preparation and you have a little mechanical exposure, try to think of something like Biodentin or even maybe a calcium hydroxide covered in a resin-modified glass ionomer. You want to make sure that you have something that does not contain resin touching your pulp tissue on your tooth. What they found that in these cases, almost 100% of the cases that were covered with Biodentin had a complete dentinal bridge. So the Biodentin folks, good job. It's a great material for that. It is tough to work with. I often cover it with a resin-modified glass ionomer just because it can wash out. But just make sure resin-containing products, especially if you're in the Army and you're active duty, don't do a definitive pulp cap with a resin-modified glass ionomer or a resin-containing product. So here's an example of a patient we actually got really good follow-up on. This is one of my residents, Dr. Sensendiver. She was on sick call over a holiday weekend, and this patient presented to us. And we can still do CAD/CAM restorations on patients like this. They don't necessarily have to get a root canal when they present to us like this. We use this Biodentin by Septident, so if you haven't used it, the basics of how you use it is there's a powder and liquid. You mix 5 drops of liquid into the powder and you shake it for 30 seconds in an amalgamator, which is probably the only use I get in the state of California now for my amalgamator. And then we go ahead and we place this over top of our mechanical exposure. So you can see this is what her restoration looked like the day of that pulpal injury. So we ended up bringing the patient back 3 weeks later and 6 months later to reevaluate and do pulp vitality testing again. And overall, here is our final restoration that patient had. So day of and follow-up from that patient getting this restoration completed. So patient still has a vital nerve on the tooth, so we have to understand if we treat our tooth properly from a biological perspective and cover it with a material that respects that biology, we can maintain our pulp vitality. So now we're on to the crown and bridge stuff, right? So we know that it's going to be a long road of failure on teeth. Whenever we restore a tooth, we have to prepare the patient that it's starting the life cycle of that long road of a DO, an occlusal. That occlusal and DO turn into an MOD, which turns into an onlay. So we have to figure out different types of materials to protect our tooth over the long haul. So as we're moving forward and we talk about our material classifications, I think the residents and I spent, about 2.5 hours this morning talking about dental materials. I promise we won't do that. All I'm going to put up here is a little bit of basic stuff on where we're at with our CAD/CAM material classifications and how this relates to the ABCs that I'm going to have you walk away with from this lecture. Okay? So what we have in the realm of dental materials are provisionals, hybrids, ceramics, and polycrystallines, and we're talking about our CAD/CAM materials. From there, we can have something that's high aesthetic or high strength, but when it comes to bonding, don't wrap your mind around each individual material and think, well, how am I going to stick this to that tooth substrate? I want you to break it into a couple different classes, okay? So this is where the ABCs really start to come in. You want to break your materials down into glass materials and not glass materials, okay? So as we're looking through the ABCs for the rest of this lecture, I want you to think of everything that we talk about as either it is glass or it is not glass, okay? So is it glass or not glass? We know our biological substrate in this case is going to be dentin, but if it's going to be a gold post, we have to then take that gold post into consideration and understand that our bonding substrate, our B, could be a little bit different. And then when it comes to our cement type of cure, we have to understand, can we cure through our material, and how is that going to impact our cement selection? So before we start, we've got this tooth isolated. So this is how I bond a single unit CAD/CAM restoration. I live in the world of the number 7 and the number 14 clamp, or the 14A clamp. And what I do is I clamp just that one single tooth, put my rubber dam on, and then I'll actually take a piece of dental floss and run it underneath my rubber dam clamp and ligate it, and it'll actually pull it down underneath my margins. So that way, when I go to bond this restoration on, all of my rubber dam is down below my margin, and my tooth is nice and isolated. This takes all of about 30 seconds to put the rubber dam on. It doesn't take a long time. It may be intimidating the first time you do it, but trust me, it'll make your CAD/CAM restorations go a heck of a lot faster. So then we're going to get this restoration clean, like we talked about in that 1980 study. So Pascal Magnier says what we should do to get our immediate dent and seal clean is we should gently aerabrade our restoration and then re-etch our enamel, which is what you can see here. And because we have a dent and seal over top of it, we're etching everything to remove our phosphate contaminants. So this is all done very quickly chairside to prepare us for our crown. So now that our tooth is ready to accept the crown, we have to understand the A, okay? So in this instance, I'm using what's called a lithium disilicate crown. So for the room, is it glass or is it not glass? It's glass. It's a glass crown, okay? So for a glass crown, what we're going to remember is that if we increase our glass content, we're going to increase our acid concentration and we increase our etching time. So you don't have to be a wizard and remember every single dental material on the market. What you have to remember are trends. So when we think of something like lithium disilicate, it's 70% crystal, 30% glass. So we do 5% acid etch for 20 seconds. When we think of something like feldspathic or even like an Empress, we're 60 to 80% glass with 20 to 30% filler. So we're going to increase our etch concentration to 9.8%, and we're going to increase our time to 60 seconds. So if you understand those general trends, more glass, more time, it's going to make your life a lot easier. Now, if you forget that, don't freak out. You're going to be okay. What we found out through multiple research articles is that really what we want to do is follow the manufacturer's minimum etching time. So if you're working in a clinic and you don't know what type of material it is, if you don't know if it's Emax, if you don't know, but you know it's a glass, but you just don't know what the glass content is, I would default at etching it for 60 seconds. If you accidentally etch Emax for 60 seconds, you are not going to destroy the material. There's no study that'll show you're going to destroy the material. You'd have to etch it for greater than 120 seconds with a 10% hydrofluoric acid to damage that microtensile shear bond strength. So what I tell people are the numbers you remember for your clinic. If it's a glass, you're going to use 5 or 9% hydrofluoric acid for 20 or 60 seconds. That's it. You don't have to remember anything more complicated than that. If it's a glass, remember that bottom box. Okay? Some people like to use etch and prime. That's okay. It just doesn't have a lot of data. I think in an environment like the Army Dental Care System or a school environment, it's a lot safer material. You're not worried about the environmental hazards of something like hydrofluoric acid, so it's a little bit safer for you. I joke to the residents that it's kind of like my hair versus my wife's hair, right? Like my hair doesn't require a lot of care, doesn't require a lot of maintenance, so I can maybe stick with this 3-in-1 type of etch and prime system for my hair. If you've got something like a veneer, something that's more technique sensitive, like my wife's hair, she's got 3 bottles of shampoo and conditioner and post conditioner. You maybe want to stay away from the etch and prime. So think of as the complexity of your restoration and the importance of your dentin bond increase, you want to make sure that you're not using something like this, which maybe is going to not condition our crown adequately. And that's what this study says. It says from the limit of what we have available, it could be a great pre-treatment method compared with etch and silination by itself, but realistically it is a very short study and more studies are needed to verify these results. If we're using non-glass, we have to think of air abrasion, okay? So with glass, we're using acid. With non-glass, we're using air abrasion. So as a default, you want to make sure you're using aluminum oxide at approximately 20 psi or 1.5 bar. And what that's going to do is going to roughen the non-glass surface. So I even lump zirconia into non-glass. Zirconia is not a glass. Zirconia is a crystal. So if you're going to bond a zirconia crown, we have to first pre-treat it with acid or with air abrasion, not with acid. So this lumps composites, zirconia. With gold, it's a little bit different because gold, when we get further on down the line, we are going to vary a little bit from our composite zirconia and titanium. But if you wonder, is this studied, is this in the literature, is this supported, or is this just my idea? It is supported. So Marcus Blatz, who's probably the world-renowned guru on bonding zirconia, his recommendation is 1.5 barometric pressure with a chair side or lab micro etcher of aluminum oxide. The reason I recommend aluminum oxide versus glass beads, because people ask me that a lot, well, can I use glass beads because it's going to be softer? No. Glass beads are like a tennis ball. When you look at them under a microscope, they look like a round, fluffy tennis ball. And what's going to happen is they're going to hit your zirconia surface, and they're not actually going to make any sort of mechanical change to that surface. When we look at aluminum oxide, aluminum oxide looks like these little rocks. So it's like throwing a rock at a window. Yes, you could crack it, but if the rock is small enough and thrown at low enough pressure, it's probably just going to leave a little mark. All we want is that little mark left in the zirconia to then prep it for what we're going to do next, which is our bead, or our bonding to our substrate. So when we look at this, with the glassy materials, what we've done is we've applied a hydrofluoric acid etch. The next thing, our B, or intermediate substrate, is going to be silane, okay? So it comes in two varieties, which you typically see is pre-hydrolyzed in a single bottle, or the dual bottle, where you have ethanol and acetic acid that you mix together to then hydrolyze it. When we go through this type of reaction, what we find is the majority of them on the market are this MPS of molecule. And what this MPS molecule does, it goes through a 2-series step of what's called deprotonation, or we lose a hydrogen. And then when we lose that hydrogen, we actually attach to our oxygen of our silicon. So what does that mean? Okay, so for the non-chemistry nerds in the room, what that means is that we have a covalent linkage, a very stable long-term linkage between our silica in our ceramic and our silane. If you notice, if you're a chemistry buff, you can see this little C double bond right here. This is where our composite is going to attach. So we have a covalent linkage, and it's going to be a covalent linkage right here. So it's very long-term stable in our glass ceramics, okay? So that's super important to remember. When it comes to non-glass, we have to think about it a little bit differently, okay? With non-glass, we're not going to get that covalent linkage like we talked about. So in anything but gold, this is what we're going to see. So up here, we have a product called MDP, or 10-MDP. That phosphate group is going to go ahead and it's going to attach to our zirconia, and it's going to create a linkage between that and our silane type of molecule. So with that, what we have to understand is that methacrylate monomer has that attached functional group. How many people, when they try a crown in, use phosphoric acid to clean it out? Anybody? No? Okay, good. Don't do that with zirconia. There's a lot of people that'll take crowns, and after they try them in, they'll clean it out with phosphoric acid and they'll rinse. If you do that with zirconia, it creates a big problem. What happens is that phosphate and the phosphoric acid binds to your zirconia after it's been aerated, and you don't get any bond whatsoever, and you get delaminations, or zirconia crowns just pop right off. So zirconia is super critical to keep in mind. So if we don't introduce phosphoric acid, we can create this stable linkage like we see right here. The only difference that I would say is gold. Okay, gold requires what's called a sulfate linkage. So if you're going to bond gold posts or gold restorations, what I recommend keeping in the clinic is something like Monobond Plus. Monobond Plus has every single type of bonding system in there. You have silane, you have MDP, and you have a sulfate linkage. If you have something like Carrari and you have their ceramic primer, you're going to have MDP and you're going to have silane, but you don't have the sulfate linkage. So if you find yourself doing a lot of gold posts and you want to bond them in, I would probably stick with something like Monobond Plus. Now that we're on to cement selection, okay, so we've gone through our A and our B, we have to work on C. I think a perfect way to think of this is kind of like a stoplight. If anyone is familiar with the Reliax brand of products, you have Reliax Luting Plus, which is pink. So let's just pretend it's red for the picture. You have Reliax Unisem, which is yellow. Okay, so let's think of it like the yellow. And then you have Reliax Ultimate, which is green. Okay, so that's your resin cement. So you have a luting cement, you have an adhesive resin cement or a self-adhesive, and you have your standard resin cement. So this study from 2014 went through and looked at these different indications of how we can do these restorations. What I tell people is, think of it like this. If we've gone through all of the steps of bonding a tooth and we've gotten good isolation, are we going to want to use a resin modified glass ionomer? No, stop. It's a stoplight. Don't use it, okay? What we're going to want to use is some sort of resin cement that's going to complement all of the things that we just did with our acid or air, and our intermediate bonding substrate. So we're going to want to use either Reliax Unisem or we're going to want to use, Reliax Ultimate. But you can apply that to any of these different materials, right? There's lots of different ones on the market. You don't have to stick with one. So what I told the residents today is think of it like this. If you're in the world of bonding and we're in the world of ABCs, trying to stick these crowns to a substrate, doing a dent-in bond, what we're going to use for our red cements or our luting cements are teeth that have proper retention and resistance form, and materials that we didn't go through the whole bonding protocol on of acid or air and bonding intermediate. We're going to use our yellow cements or like our Reliax Unisems or our self-adhesive resins on posterior. So areas where we're not worried as much about color stability, because that's the big concern we have with things like Reliax Unisem or like Calibra Universal. Those cements tend to not be as color stable because you're mixing in more acidified monomer into your self-adhesive resin cement, and they tend to be less color stable with time. So if you want to bond restorations and you want them to look nice long term, stick with a conventional resin cement, something like Reliax Ultimate, something like Panavia V5, something like Multilink. That's going to give you a nice long-term stable color, and it's going to complement the acid or air and the bonding substrate that we did very nicely earlier on. Don't be super concerned about film thickness. And the reason I say this is, John O'Burgess published an article years ago that talked about the film thickness of resin cements and how thick they were. Nowadays, when we look at resin cements, all of them are below our acceptable limit of 25 microns. Just thinking of the Reliax group of products, those typically fall in the range of somewhere around 12 to 16 microns of film thickness. And ultimately, when it comes to our all ceramic restorations, what we're trying to avoid is super thick cements above 300 microns, because that's really going to start to affect our CAD CAM restorations. Anything less than 300 microns when it comes to the film thickness isn't really going to affect the fracture strength or the compressive strength of our restorations. So on a restoration like this, we cure and we manage our O2 inhibited layer. And for this, because it's Emax, it's glass, we acid etched. Because it's Emax and our bonding intermediate was it silane or was it 10 MDP? What do you think? Silane, right? Because it's a glass. And then from a C perspective, we have rubber dam isolation. We want to complement this because this is a minimal retentive prep. We use a standard resin cement like Reliax. So walking through something like this walks you through my workflow of how we bond all ceramic restorations. So when you get back to your clinic, and if you decide to do all ceramic or CAD CAM restorations, you have to understand these different types of materials. You don't have to know every single one of them, but you have to understand if they're glass or if they're not glass. And that's going to tell you if you need acid or if you need air abrasion. Once we figure that out, you have to just understand at least two things. Silane for your glass, 10 MDP for your non-glass. If you're a big gold user, stick with something that has a sulfur linkage in it, like Monobond Plus. When it comes to cements, I typically will use light cure cements for my thin veneers, dual cure for thick veneers or most all ceramic crowns, and the only time I'm using the self-adhesive dual cure resin cements are for things that I truly can't cure through. So something like Reliax Unisem, I would probably use on like a zirconia crown that I'm trying to bond because of retention and resistance form issues. Overall, if you're interested in having any sort of handouts to make your life easier, I'm more than happy to include any handouts. You can come up to me afterwards. If you leave your email address on your feedback form and you want one of us to send you the slides or send you the handouts, I'll be more than happy to share any of the handouts I shared with the residents. If you don't feel like having me reach out to you through the evaluation, reach out to any of the residents or the mentors. I gave them a lot of CAD CAM stuff this week. I'm more than willing to share with anybody. I don't get paid for anything that I present or anything that I do other than just getting my TDY costs reimbursed. I just enjoy doing this. I find digital dentistry fascinating. I find the world of minimally invasive preparations fascinating. And ultimately, I want to make it less mystifying to people and try to make easy ways for people to deliver high quality restorations in a very short time for all of our patients. So in conclusion, there's a lot of papers that I referenced, talking with the dental resident that was here, working with them, developing these topics. It's really, learning back and forth. Students always bring things to me, questions to me that I then have to research, and ultimately kind of builds these topics out. So I appreciate you all listening. It's the first time I've given this lecture because it was kind of something that we had just developed a few weeks back, and we think that the ABC concept, applying that to bonding your CAD/CAM restorations, is a really easy way to distill down what steps you need in order to make sure you have the highest chance of success to getting your restorations to stick to the tooth you're trying to get them to stick to. Other than that, I'm open to any questions y'all may have.
I was just, when you were talking about if the tooth gets contaminated, re-etching it, it brought to my mind, I saw an argument people were having on Facebook a little bit ago because the guy brought up a question if he was prepping the tooth, was putting the bonding agent on when, I don't remember if he said he started having some bleeding or saliva, something contaminated it. So he rinsed his bonding agent off, and then he was debating whether he did the right thing or not because he didn't re-etch because he didn't want to over-etch the tooth. So do you have any concern with over-etching the tooth if you're re-etching after contamination?
Not necessarily, no, because if I'm trying to clean a contaminant off, I don't use the phosphoric acid for nearly as long. So if that were to happen to me, so I immediate dent seal. So if I slather it with phosphoric acid etch afterwards and air abrade it, my dent's covered. I'm just modifying my resin-coated surface. That's all I'm modifying. But in that case, what I would do is I would want to clean off that contaminated bonding agent because now our hybrid layer, has potential for having hydrophilic particles and phosphate particles mixed in. I would take phosphoric acid, I would take a micro brush, and I would scrub the heck out of the restoration for about 5 seconds to try to clean all of that out of there. And then I would lightly air dry it to see what that looked like. If I was using something like a self-etching bonding agent, something like Scotch Bond Universal, I'd really depend on how much contamination we got as to what I would do. But if I'm cleaning contamination, it's typically like a 5-second etch because I'm just trying to, it's almost like eggs in a frying pan, right? You crack an egg in a frying pan. Imagine turning the heat on is like taking phosphoric acid into saliva and it causes the egg to congeal and you can slide it off the pan. That's kind of what I'm trying to do when I'm using phosphoric acid to clean out the saliva. So hopefully that answers the question.
That was great.
Are you scanning before you immediate dentin seal or after?
After. Yeah, so typically what I'll do is when I scan a patient, that immediate dent and seal is going to make my scan easier, my insertion easier. It's going to make the milling algorithm smoother. So my immediate dent and seal and resin coating, after I prep and remove all of my decay, I do my etch, I do my bond, I wipe off my excess bonding agent, cure, put on my low viscosity flowable, wipe off the excess, cure, and then I run a diamond around my margins really quick just to make sure I clean all of it up, and then I'm scanning.
You dull out that resin if it's too shiny for your scanner?
You can. So now that a lot of clinics have 3D printers, you've got a unlimited supply of isopropyl alcohol. So isopropyl alcohol, that's not from your resin vat for curing, on a little cotton swab to scrub that will remove a little bit of that uncured layer from the top and will make it look a little bit less glossy. I typically don't remove that anymore. I used to, but now that I have this really nice air abrasion unit, which I have right here. This is an ECAP, so if anyone's interested, I can share with you the part number. Now what I'll typically do is I'll get a good scan, and then before I bond, I'll air abrade the surface to roughen it up afterwards. Air abrading with aluminum oxide, there's some studies that show it can increase bond strength by 200 or 300%. So, especially in these minimally retentive preparations, I want to try to maximize that as much as humanly possible.
Well, I just want to say thank you so much. It's been fun it's been an honored week for me to have him here. On top of it, I know we had a lot of trouble getting you here, but I'm so glad we finally made it happen. As our commander has a
Awesome. Thank you so much.
bite of the eagle coin for you, as showing
All right.
our appreciation for being here and teaching them biomaterials, CAD, CAM, crowns, bras, you name it. We have been going at it for the past 2 days, and we're going to go at it again tomorrow.
Yeah.
So, thank you, and a little airborne
All right.
shirt for you.
Awesome. Thank you so much. I really
Yes.
appreciate it. And we'll see how cold it is tomorrow if I make it out for the ACFT with you guys. I'd like to be there and stick it out with you. But, now that I've gone soft living in California, if it's below 30 degrees, I don't know if I can go out and do PT in that, that cold grass.
Yes, I truly do appreciate it, and we all
Thank
do
you
over
so
here.
much.
Thank
And
you.
if you have any questions, if you want any of this, like I said, reach out to me. I'm the admin of the Army AGD for our education, so you can reach out to that admin email on our website. If you want to reach out to my military email, I'm in global. Whatever I can do to help you along your CAD CAM journey, I'm happy to help anyone who wants to talk to me. So.
And he's lecturing tonight again to the Army AD. So he's been having 2. Yes.
That's it.
That's
all, folks.
You guys should receive, as you fill out that
Oh, yes.
form, and your email should receive a certificate